Hi, I'm Dr. Rawan. Today we will cover how to approach pneumonia and bronchiolitis in children, how to tell them apart, what to look for on exam, when to investigate, and practical management and escalation steps. By the end, you will have a clear stepwise approach you can use on the wards or in a clinic. By the end of this video, you'll be able to recognize typical history and exam findings for pediatric pneumonia and bronchitis, know which investigations to order and when, understand first-line management, red flags requiring admission, and prevention measures. I wanted to start my presentation with a quick case. Here, I wanted to show you a case that I admitted to the pediatric emergency of the hospital I was working in, a 2-year-old female patient complaining of poor feeding, 2 days of cough and fever. On the auscultation, she had no wheeze at the baseline. You can see the way she was breathing. You can clearly see the retractions. So, how do you approach this child? Let's break it down. Starting from the definition, pneumonia is an infection of the lung parenchyma, usually producing consolidation, hypoxia, and focal signs on the exam, while bronchitis describes inflammation of the airways and produces cough and wheeze. Pneumonia is an important cause of morbidity and mortality worldwide, especially in pediatric population. We should focus on the common causative agents according to the age. That's how we're gonna be treating these patients. So starting from the neonates, most common causes are group B Streptococcus, E. coli, and Listeria. In infants and toddlers, let's say from 3 months to 5 years old, most common causes are viruses, especially RSV, rhinoviruses, influenza, parainfluenza, and so on, while most common bacterial causes are Streptococcus and Haemophilus influenza. In older children, which are older than 5 years, atypical pneumonia can be seen. And the most common causative agents would be Mycoplasma pneumonia and chlamydophilia, while the most common cause of typical bacterial pneumonia is Streptococcus pneumonia. So what to ask the patient's parents and how to approach these patients, starting from the onset and course. If the patient has sudden high fever and toxic appearance, then suspect bacterial pneumonia. If the patient has gradual onset with persistent cough, then suspect viral or atypical pneumonia. Ask for the respiratory symptoms. Is there any cough? Was the cough productive or dry? If there is a sputum, which color was it? Is there any wheeze or noisy breathing or even a stridor? Inspect for work of breathing. Is the patient having any tachypnea, nasal flaring, or chest retractions? These are all important markers of severity. Ask about the feeding and hydration. Look if the patient looks dehydrated. Ask about the vaccination history, prematurity, chronic lung diseases, immunosuppression. These are all risk factors of bacterial pneumonia. But for bronchiolitis, the patients usually are younger than 2 years old. They have wheeze, crepitations, feeding difficulty. You can see apneas in very young infants. And here's a deep note. Normally, bronchiolitis starts with rhinorrhea. Like they have nasal discharge at the beginning of the disease. On the examination, what you should concentrate on is really general appearance. Trust me, as an experienced pediatrician, I always look for general appearance. So people with pneumonia, patients with pneumonia, normally present with really lethargy or toxicity. So general appearance is often the single best predictor. Next, you should look for vital signs like heart rate, blood pressure, or most importantly in this case, respiratory rate. Who tachypnea thresholds have charts. You can know the specific respiratory rate for each age. You can check for that table as well. Next, what you should look for. In the respiratory exam, we always know that you have to auscultate the patient. You may hear some focal crackles or decreased breath sounds. From my experience, I mostly heard decreased breath sounds in the affected area. For example, if the patient had lower lobe pneumonia, you hear decreased breath sounds there, more than you can hear crackles or rails or so on. Look if there is any work of breathing, if there was any retractions as we saw in the previous video, nasal flaring, especially in neonates, head bobbing, grunting. These are all indicators of increased effort. Observe feeding, capillary refill, and hydration, like check the patient's fontanelles, turgor, and so on. And don't rely solely on auscultation. As I told you, it may mislead you. So, you took the history from the parents, you examined the patient. Next, how to investigate? Well, all the patients should be checked for their oxygen saturation. You can check all the patients with the pulse oximetry. We usually want it above 95%, but if it was lower than 90%, then trust me, you shouldn't send this patient home. I mean, I wouldn't. Chest x-ray is not required for every child, but obtain chest x-ray if the patient is hypoxic, if he or she has severe disease, atypical course, if you have treated this patient with oral antibiotic but there is a failed outpatient therapy. So to evaluate the complications, order a chest x-ray. Here I presented an x-ray of a 4-year-old patient who admitted to the hospital complaining of 3 days of cough and fever. And as you can see, she has lobar pneumonia. The diagnosis is confirmed by the consolidation we're seeing in the right middle lobe, as you can see here. Blood tests, you shouldn't ask for blood tests for all the patient. Consider complete blood count, CRP or procalcitonin in moderate to severe cases, but they don't really rule in or out bacterial disease. Blood cultures can be obtained from patients, from some patients, let's say, febrile infants or even neonates. Nasopharyngeal viral testing does not really change the management, but to confirm the viral etiology, you can ask for it as well. Ultrasound, if you are suspecting any pleural effusion or MPMA, you can ask for them. So, moving to the management. Managing bronchiolitis is supportive care is the mainstay, let's say, like ensure hydration, nasal suctioning, oxygen for hypoxic patients, and observe feeding. But bronchodilators and antibiotics are not usually used. But for management of pneumonia, it's very important to decide if the patient has any bacterial or viral pneumonia. Depending on the causative agent, you're going to be treating this patient. If the child has high fever, focal chest signs, hypoxic, or is very unwell, then treat for possible bacterial pneumonia. Here you have two options, outpatient or inpatient. In outpatient cases, many children with mild pneumonia can be treated at home with a close follow-up. Make sure that the parents can admit to your emergency again if they have any worsening symptoms. So if you're going to be treating this patient outpatient, like if you're going to send them home with oral antibiotic, then for typical pneumonia, you can subscribe amoxicillin, but for suspected atypical pneumonia, subscribe macrolide like clarithromycin or azithromycin. But if the patient is severely ill, if he or she is younger than 3 months, if he or she has any respiratory distress, then treat this patient in the hospital by giving them empirical IV antibiotic. Usually we use ampicillin sulbactam 50 mg per kilogram per dose 3 times a day, but if it's severe, then you can upgrade it to 4 times a day, maximum of 2 grams per dose. But if the case is ampicillin sulbactam resistant, then you can subscribe ceftriaxone. But for complicated pneumonia, involve pediatric surgeons or interventional radiologists and consultate the patients to these branches as well. So what are the red flags and when to escalate? Persistent or worsening hypoxia. If there's any marked work of breathing, apnea, cyanosis, poor perfusion, decreased consciousness. If the patient's age is under 3 months with fever or any respiratory distress, or if there is any rapid clinical deterioration, persistent fever despite the treatment, or evidence of complication. How to prevent? Well, by giving the vaccines, the pneumococcal conjugate vaccines and Haemophilus influenza type B can be helpful, and all influenza vaccination reduces influenza-associated pneumonia, which we can see very frequent in the emergency department. Good hand hygiene always have to be reminded, and reducing tobacco smoke exposure are important stuff as well. Ensure outpatient follow-up. Ensure that the patient can admit to your emergency in 48 to 72 hours after managing the pneumonia. And if there are any symptoms that are worsening with time, remind the parents to admit to your emergency department beforehand. So, work of breathing and oxygenation predicts severity better than chest auscultation alone. Most pediatric low respiratory infections are viral, so avoid routine antibiotics for bronchitis and use local guidelines for antibiotic choice and admission threshold. Don't miss poor feeding or septal leukopenia in infants. Don't over-rely on X-ray because it can be misleading, especially early in the disease's course. So to sum up, in children, distinguish viral bronchiolitis from bacterial pneumonia by assessing appearance, work of breathing, oxygen saturation, and focal chest findings. Manage bronchiolitis supportively and reserve antibiotics for suspected bacterial pneumonia. Escalate early for hypoxia, severe distress, very young age, or comorbidity. If you found this useful, like and subscribe and tell me in the comments which pediatric respiratory topic I should cover next. Thank you for watching.